Hello and welcome again to our weekly EKG series. I'm John Felt and I'm joined again by Dr. Sriram with the Department of Pediatric Cardiology. We have another case this week. This is a 15-year-old female who presented to the emergency department. She came with a chief complaint of fever, cough, and difficulty in breathing, as well as intermittent chest pain. She did have a history of arteriovenous malformation, asthma, and obstructive sleep apnea. She was worked up for her chief complaints. A chest x-ray ended up showing a right middle lobe pneumonia, but in addition, bedside EKG showed the following.
All right, so how old was this patient again?
15 years.
15. So we have a 15-year-old young lady who has cough and congestion and the clinical signs and symptoms suggestive of right middle lobe pneumonia, who incidentally on the ECG was noted to have this rhythm.
Yes.
So clinically hemodynamically stable, I'm presuming.
Yes. She was having a little bit of trouble breathing, had maybe a slight increase in her respiratory rate, but that was about it.
And was she feeling any palpitations at all?
She thought occasionally that she was, yes.
All right. So right off the bat, you look at this ECG, and what strikes you is the change in the morphology of the QRS. Mm-hmm. You look at the ECG and you see narrow QRSs followed by wide QRSs, and so you look for the underlying rhythm to see if there's a sinus rhythm going on or if you have something else going on, and you clearly see distinct P waves, as I can highlight. You see these nice P waves that are positive in 2, 3, and AVF, and are and then they're positive in 1 and AVL, and they have this pattern suggestive of underlying sinus rhythm.
Okay.
So that's the first thing to note, and you note the PR interval is normal, and the P waves conduct to the ventricle normally with a narrow QRS.
Correct.
And following that, you have this wide complex beats that seem to follow in a bigeminal pattern. So you have this narrow complex sinus rhythm followed by a narrow complex conducted beat, followed by a wide complex conducted beat, then followed by a sinus narrow complex, then wide complex. So in that setting, the thing to determine is you have a bigeminal pattern, and the question is this an atrial bigeminy with aberrant conduction versus ventricular bigeminy?
So by bigeminy, you're meaning the pattern that you see.
Yes,
so
the pattern.
A narrow complex followed by a wider complex followed by a narrow.
It's a pattern of it's a group pattern. You have you have a pattern of narrow complex followed by wide complex, and because it alternates, it happens in a bigeminal pattern.
That's the definition then of bigeminal. Okay.
So it's nothing to do with PVC or PACs. You can have atrial bigeminy or ventricular bigeminy.
Okay.
So the question is, if you have atrial bigeminy, then you have a sinus rhythm followed by a P wave that is ectopic, comes somewhere else from the atrium.
Okay.
And that can conduct to the ventricle with a narrow QRS or a wide QRS in the case of an aberrancy if it blocks in one of the bundles.
Okay.
So in that case, that would be an atrial bigeminy. And if there is no P wave to make that QRS and it's wide, then you have to assume that it's a ventricular bigeminy.
Okay.
There are rare instances where you can have a PAC that can be conducted to the ventricle with a pre-excited pattern, but that's pretty rare. So I think the first thing you should do is clearly look for any hidden P waves that you can see. If you can see that any funny looking T waves that might be hiding a P wave, and sometimes it's hard and it's not very obvious that there are any P waves here. So
is there particular leads that you focus on to try and see that, or?
Well, you look at all the leads and look at the T waves to see if they are funny looking T waves, like unusually tall and spiky, which may be suggesting that they're hiding a P wave. Mm-hmm. So you don't distinctly see that, and then you see this wide QRS, right? Mm-hmm. So the question is, could there be a PAC that is hiding, that is conducting aberrantly, versus just a PVC that happens in a bigeminal pattern? And sometimes it may not be that easy to spot a PAC. And if you have a wide QRS beat, and if it doesn't look like it's conducted through his Purkinje conduction system, then you have to assume that it's a PVC. So in this case, you look at the morphology of the QRS, and you would note right off the bat that 2, 3 AVF are completely positive.
Mm-hmm.
and AVR and AVL are completely negative, right?
Yeah.
So that suggests that the origin of the ventricular activation is happening in the outflow tract region. Because when you have 2, 3 and AVF positive, that means that the axis of the ventricular activation, which is causing that white complex beat, is happening somewhere anteriorly or superiorly in the ventricle.
Okay.
Then if it's negative in both AVR and AVL, then it's neither coming from the right side or not coming from the left side. You have so it's probably coming very high up in the outflow tract. And this is a pattern to kind of memorize. If you have a pattern where you have clearly positive QRSs in 2, 3 and AVF that are wide and are completely negative in AVR and AVL, that suggests that the origin of the ventricular activity is not from the His-Purkinje conduction system, because usually that's not a pattern that you will see with His-Purkinje conduction system.
Okay.
You will have some sort of S wave or a Q wave in or S waves in those leads that will tell you that it's not completely coming from the outflow tract. If it's coming from the outflow tract region, then there is no His-Purkinje conduction system that can cause that morphology of a QRS there.
Okay.
So that by default proves that this is outflow tract PVC.
Mm-hmm.
So there are other clues too that you can look at, and you can look at this and say, well, on the lead V1 I have a left bundle branch like morphology, suggesting that I'm activating the right ventricle first.
Okay.
Because V1 is a precordial lead, and it's an anterior lead, and it's a rightward lead as well. So any PVC coming from the right ventricle would be going away from that lead and would produce a left bundle branch block morphology.
Right.
Any PVC that is coming distinctly from the left ventricular free wall is going to go towards the lead V1, and it's going to make a positive or right bundle branch like QRS on that lead.
So you in the right ventricle, you mean?
No, if you have a PVC that is coming from the right ventricle, usually that is going away from the right ventricle because that's the site of origin.
Okay. So then it would be
And
negatively deflected.
because it's lead V1 is looking at the right ventricle, and it's anterior as well as a rightward lead. So PVC coming from the right ventricle would be going away from lead V1.
Okay.
That would produce a left bundle branch block morphology.
Okay.
Conversely, a PVC coming from the left ventricle
Is going to
be the opposite. It's going to produce a right bundle branch like morphology.
be
Obviously, there
positively
can be PVCs coming from the septum that can have intermediate morphology.
Right.
But the fact that you have a left bundle branch morphology with a outflow tract morphology suggests that this is probably coming from the right ventricular outflow tract.
Okay.
And the reason why that is important is that usually right ventricular outflow tract PVC is one of the PVCs that can be associated with a structurally normal heart.
Okay.
So there are a bunch of, because people with normal hearts can still have PVCs and VT, and their morphology, usually the benign PVC morphology, is usually a right ventricular outflow tract PVC morphology.
Okay.
Sometimes it can be left ventricular outflow tract, but right ventricular outflow tract morphology is much more common. But obviously you can also have right ventricular outflow tract morphology if you have pathology in the right ventricular outflow tract.
Okay.
In certain patients like ARVC and other conditions, if there is any pathology, or patients with repaired tetralogy of Fellow who have some pathology in the right ventricle, they can also have right ventricular outflow tract PVC morphology. So obviously the history is important.
Yeah.
In the absence of any previous cardiac surgery, then obviously you know that this patient doesn't have any congenital heart disease. And the next step would be to, obviously you do your due diligence and make sure the electrolytes are all normal.
Right.
But usually they're not. They're usually normal.
Yeah. And in her case,
In her case, it was.
Yeah.
And then you kind of look at this and see, and try to examine the patient to see if you can uncover any cardiac exam findings that might be positive. Maybe. So I think doing an echocardiogram in this patient, usually these patients have already had echocardiograms because they've been evaluated in the outpatient setting.
Mm-hmm.
And if you have an echocardiogram that was done before and it shows a structurally normal heart, then you can assume that this is a PVC associated with a structurally normal heart.
Okay.
And the right ventricular outflow tract pattern is consistent with that. Obviously, the resting ECG in the absence of PVC also gives a clue.
Mm-hmm.
You look at the QRS when the sinus beats conduct to the ventricle, and they look pretty normal. The QRSs are narrow. There is no baseline pathology. The T waves are normal.
Mm-hmm.
There is nothing to suggest any depolarization or repolarization abnormalities of the QRS T wave segments. So this suggests that the baseline ECG, when you don't have a PVC, is normal. And that's a good clue as well. Sometimes, rarely, you can have patients with arrhythmogenic right ventricular dysplasia that will have PVCs coming from the outflow tract, although they can have PVCs coming from anywhere in the RV.
Okay.
And in those patients, usually you might find some changes in the QRS and T waves. Usually they have inverted T waves.
Okay.
In the precordial leads, extending beyond V2, V3, and they might even find an epsilon wave. Those patients are more likely to have sustained tachycardias.
Got it.
So really, the prognosis of this PVC really depends on its association. Usually this is a PVC that is found in structurally normal heart, and if everything based on the baseline ECG and the echocardiogram suggests that it's a structurally normal heart, then you can relax. Then really treating this PVC would depend upon a few things as to how symptomatic the patient is, how frequent the PVCs are they frequent enough to cause any ventricular dysfunction. One good idea would be an outpatient evaluation, have an exercise stress test,
Mm-hmm.
and see if the PVCs are adequately suppressed.
Okay.
And it's also a good idea to have a 24-hour Holter to characterize the PVC burden. And kind of that gives us an idea, sort of determines how frequently you need to monitor them. If it's happening very infrequently and there's no non-sustained VT, then you may monitor them not too frequently.
Okay.
But if you see 30-40% PVC or more than 20% PVC and then you start seeing non-sustained VT, obviously then you have to make a choice. Usually in the absence of any non-sustained VT that is fast, in the absence of any significant symptoms like syncope or major tachycardia, in the setting of a structurally normal heart, and in the PVC that are suppressed with exercise and ventricular function remaining normal, on follow-up you don't have to treat those PVCs.
Okay. So what is the significance of a bigeminy rhythm? What is the immediate danger for these patients? The ventricular tachycardia alone, or is there other?
No, a lot of these patients may just have PVCs without any sustained ventricular tachycardia.
Okay.
If you see it for the first time, obviously it's a good idea to have them be evaluated by a cardiologist as an outpatient.
Okay.
This is not something, if you already have an echocardiogram that says that the patient has got structurally normal heart, I don't think you need to admit them for that reason if they're asymptomatic.
Okay. But if they've not, then it'd probably be a wise idea to
It may be wise to talk to the cardiologist and see if it would be possible for them to get an echo the same day or have them see in the clinic within a week or so and have that echo done just to show that the heart is normal. Again, the fact that you can make some conclusions based on the fact that the patient is asymptomatic and the baseline ECG is normal,
Mm-hmm.
that alone will tell you that things are okay. And in the ER, if you want to go a step further, you can do an NT-proBNP and check if its NT-proBNP is normal. There's nothing to suggest any ventricular dysfunction or things like that. Then you can rest assured.
Now, in this patient, she was acutely ill with a pneumonia. So would you assume that she would have had the same bigeminal pattern previously when she was otherwise well, or was it the infection itself that set that off?
Right. One of the things that can happen is that patients with less frequent PVCs can start having more frequent PVCs in the setting of some electrolyte disturbances, other intercurrent illness.
Okay.
So that is always possible.
Yeah.
And that might be a trigger for them to have maybe some non-sustained VT as well.
Mm-hmm.
So I think it's nice to have them monitored. If there's a reason to admit them to treat the pneumonia, then it's nice to admit them
and do cardiac monitoring
and do some telemetry to see if they have anything going on. But as I said, we see this all the time in the outpatient clinic, and we don't have to necessarily treat them every time. The treatment decision will be based on the amount of symptoms, the presence of any non-sustained VT that is fast. History of syncope is always concerning.
Yes.
Obviously, you have to make sure the syncope is not vasovagal. Like if it's clearly a vasovagal syncope, then that probably has got nothing to do with the PVC.
Right.
So really, the treatment of that PVC will be based on its association with other factors, not just for the PVC alone.
Okay.
Because you don't treat the PVC, you treat the patient. And there are other things that would suggest that these PVCs are late coupled, because you look at the QRS, look at the time from the onset of the QRS of the normally conducted beat to the PVC, and you can get a sense of how closely coupled it is. In this case, I would say it's probably about maybe close to 400 milliseconds. That's late coupled. It's not 300 milliseconds or less. It suggests it's early coupled, and there is no R on T phenomenon. It's coming completely after the T wave.
Okay. So the significance of an early coupled PVC would be what?
So the early coupled PVCs are PVCs that can sometimes put the patients into ventricular tachycardia, ventricular fibrillation.
So the risk then is higher.
Again, it's not one thing. It's just, if you just saw one PVC out of several that is early coupled, all the others are late coupled, it probably doesn't mean anything.
But
if you see consistently very early coupled PVCs that are happening on the T waves, then you might be a little bit more worried.
Got it.
Again, that doesn't mean that the patient is going to have ventricular fibrillation, but that's probably a risk factor.
Okay.
In this case, I think these PVCs are coming late enough. And you can also look at the morphology of the PVCs to see if they are coming from the septum or the free wall. And in this case, you see that the precordial transition usually happens pretty late. It's predominantly negative in V1. It starts becoming mostly positive in V4.
Okay.
That's not an early transition.
Okay.
That's a later transition. On the other hand, if you saw a PVC that was negative in V1, completely positive in V2, or mostly positive in V2, that would be an early transition.
Okay.
A late transition suggests that the PVC may be coming more from the free wall rather than from the septum. Septal PVCs tend to have a much more early transition.
Okay.
And then the fact that these PVCs are showing notched QRS is also something that goes along with a free wall origin.
And
usually septal PVCs are much more sharper, and usually 10-20 milliseconds narrower than your free wall PVCs on average, and they tend to be more early transitioning, don't tend to show a lot of notching, usually tend to be negative in lead 1. And here it is positive.
And so again, a free wall origin would be a lower risk of...
Well, the septal origin would be something that is typically seen in your right ventricular outflow tract PVCs, although you can have free wall origin too.
Yeah.
A septal origin is what you typically see in the right ventricular outflow tract PVC.
Okay. And then in this patient's case, she was sent home on, I believe, diltiazem. And can you speak a little bit to the rationale for that?
Yeah, I think the patient was complaining of mild symptoms, and I didn't want to treat her for that, but I think she was supposed to have some neurosurgery that was going to be undertaken, or she was planning to have a neurosurgery done.
Okay.
And I wasn't sure if the neurosurgeons would, although we don't kind of typically worry about it too much, but it might be something, and I just felt it might be an impediment to the surgery. So I thought either beta blockers or a calcium channel blocker would be a start. I think the patient had asthma, so I think I started her on calcium channel blocker.
Yeah.
That unfortunately wasn't effective, but the patient was not symptomatic too, so we just felt there was not a great reason to continue.
So
the medicine, or put her on a medicine like flecainide, which does suppress PVCs in many situations. We didn't feel like she needed that.
Okay. So she's since then been weaned off of her...
I think she's been stopped. Calcium channel blocker has been stopped, and she probably is still asymptomatic.
Okay.
And we didn't feel like this was a contraindication for any surgery. Obviously, once you see this, people might be hesitant, and but it should be okay if they put the patient under anesthesia. They'll be obviously monitoring it. So unless the patient has runs of non-sustained VT or VT, there should be no reason to do anything different.
Okay. And then one final question. So in adult patients, obviously, it's a little bit more ominous when there are couplings of PVCs, where you see 2 or 3 coupled after a normal QRS.
So 2 PVCs after normal QRS?
Yeah.
Well, in the adult patient, again, you have to play it by their... again, the PVC, again, in and of itself, you don't treat the PVC, you treat the patient.
Right.
And what the PVC means is different in different patients. Even an adult, if you have an adult that has otherwise a structurally normal heart, no coronary artery disease, normal EF, and is asymptomatic, one can make a case for not treating it.
Got it. Okay.
On the other hand, if you have associated conditions, then you might want to, if the patient needs beta blockers for some other reason, you might consider that to see if that gets suppressed. If they're having symptoms, then you can, in addition to beta blockers, if it's not working, then you can consider flecainide in somebody without coronary artery disease, structurally normal heart.
Okay.
Again, it's just the treatment of the PVC really depends on how much it's affecting the patient and what it's associated with, and the presence or absence of non-sustained VT that is fast. You can have slow runs of non-sustained activity. You can have a couple of 2 or 3 PVCs one after the other, and that might meet the definition of non-sustained VT. But if you look at the rate of that tachycardia, it might be 110.
Right.
So that is very different from somebody having a 10 beat run at a rate of 250.
Yeah.
So I think you have to play it by, not all non-sustained tachycardias are the same. So it really depends on how fast things were. If the patient had any symptoms during the run of non-sustained tachycardia, how many beats it was. Was it, 10 beats? Was it 3 beats? How fast was it? So I think all those things would be important to consider as well.
Absolutely.
Because there is no evidence in the adult literature and the pediatric literature just to say that treating asymptomatic PVCs that are not causing any problems or not affecting the ventricular function despite being frequent is going to save the life of the patient.
Right. Okay.
So you're not treating it. But I think it's nice to recognize it and kind of keep that in mind, because if you have PVCs, then you do probably have a slightly higher odds of having non-sustained VT.
Right.
The thing that it becomes an issue is in athletes.
Yes.
And that's kind of what things are. So if you see that in an athlete, obviously you make sure the patient doesn't participate in sports till he's evaluated by the cardiologist. And if you're seeing a bigeminal pattern, obviously that should automatically disqualify him from sports. Doesn't mean that it's going to be permanent.
But until he's evaluated.
But until it is evaluated, and we do our due diligence by doing an exercise stress test, echo, and maybe a Holter. Obviously, if all those things come back satisfactory, PVC is getting suppressed with exercise, echo normal, there's no non-sustained runs of VT, then you can make an argument for allowing them to participate in sports again. But I think it's nice to have that workup on board.
Yeah.
Yeah.
Okay, well, thank you. So in summary, we have a patient here that has a EKG showing a ventricular bigeminy, most likely from the right outflow tract.
Right ventricular
outflow tract. Of concern for the emergency department physician is to be able to determine whether or not the patient has a structurally normal heart. So obviously if they've had previous echocardiograms that are available for review, you can generally feel a little bit better sending the patient home with outpatient cardiology follow-up if they have a structurally normal heart, if they have no symptoms related to this arrhythmia.
Yeah, absence of symptoms, absence of syncope, structurally normal heart.
Yeah,
those sort of things.
Exactly. Otherwise, if not, they probably should, or certainly cardiology should be talked to, and the patient, you should consider admitting the patient for a further evaluation and/or telemetry if you can't.
Yeah, I think if you talk to the cardiologist and get some more information, I wouldn't automatically admit any of them unless I had any concerning symptoms.
Right.
A lot of times it might just be having a follow-up on board. If it's possible to do an echo the same way, that's fine. In the absence of symptoms and the absence of a baseline, in the presence of a baseline ECG that's normal, and a PVC that was incidentally discovered, I don't think you're going to lose too much by waiting for a week or so to get an echo.
Right.
Obviously, if it's an athlete and if it's a question of sports participation, obviously the evaluation needs to happen sooner, and refrain from participation in sports till evaluation is done.
Okay. Well, thank
but
you.
Just seeing a bigeminal pattern doesn't mean that the patient should be admitted on the floor, because that's not. We're not treating the PVCs; we're treating the patient.
Yep.
So
a patient that you're unable to determine, those criteria of a structurally normal heart, whether or not they have symptoms or not. If they do have symptoms, those patients should be observed. And
well, presumptively, you can make some educated guesses. As I said, you can
Right.
look at the
as to where it's coming from.
where it's coming from, or you can look at the baseline ECG and be reassured that the QRS duration is normal. There is no repolarization, depolarization abnormalities of the baseline
Mhm.
ECG, and if you're, all those sort of things. And obviously, chest X-ray is an easy tool. If you see cardiomegaly,
then you know that
then
something's
you know
wrong.
something's wrong.
And as you mentioned, you can also send a pro-BNP.
NT-proBNP and the electrolyte panel. Those sort of things should kind of reassure you. And I don't think you have to get an echo the same day, as long as it's in the pipeline and there's some sort of a follow-up that is arranged.
All right.
I think it's okay. But there are a lot of nuances, and it's nice to have a discussion with a cardiologist
Right.
if you need to.
Absolutely. All right. Well, thank you so much.
Yeah. Thank you.
Yeah. Learned a lot about. So we this morning in our conference we previewed one of the videos with the residents and the faculty. They're very, very well received. So